Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Final Results of the Sunbelt Melanoma Trial, a multi-institutional, prospective, randomized Phase 3 study evaluating the role of adjuvant high-dose interferon alpha-2b in completion lymph node dissection for patients staged by sentinel node biopsy, led by Dr. Kelly McMasters. Hello, my name is Dr. Charles Balch, and I am a professor of surgery at the University of Texas Southwestern Medical Center in Dallas, Texas, and I am a surgical oncologist specializing in melanoma. Now, the Sunbelt Melanoma Trial is a seminal trial with long-term median follow-up of 71 months. The design of the trial was rather ambitious in that there were two separate protocols covering three possible arms, so that the number of patients in each subgroup available for analysis was rather small. In Protocol A, patients with a single tumor-positive lymph node after sentinel node biopsy underwent a completion lymphadenectomy and were then randomized to observation versus high-dose interferon in a standard dose schedule. In Protocol B, patients with a tumor-negative sentinel node by standard histopathology and immunohistochemistry underwent molecular staging by reverse transcriptase polymerase chain reaction. Patients positive by RT-PCR were then randomized to observation versus completion node dissection versus complete lymph node dissection plus high-dose interferon. In Protocol A, intention to treat analysis, there were no significant differences, either in disease-free survival or overall survival, for patients randomized to the high-dose interferon arm compared to the observation arm. In the Protocol B analysis, there was no significant differences in overall disease-free survival or in overall survival across the three randomized treatment arms. It is therefore not surprising that there were no significant differences between the various subgroups in terms of overall survival. The authors did state that there might be a role for high-dose interferon in select high-risk patients with unfavorable primary tumor because in one subgroup analysis, high-dose interferon appeared to have a significant improvement in disease-free survival, that is, for thicker melanomas with a tumor thickness of greater than 4 millimeters. Also, there was significant difference in disease-free survival for the adjuvant interferon group, but not overall survival in a relatively small cohort of 75 patients who were microscopic node positive arising from an ulcerated melanoma. The results in the Sunbelt Melanoma trial are consistent with the other randomized trial using adjuvant pegylated interferon conducted by the EORTC, led by Dr. Lex Egermont, in a cohort of 186 patients with microscopic nodal metastasis arising from an ulcerative melanoma, where in the EORTC study there was a significant difference in disease-free survival, distant disease-free survival, and even median overall survival that increased from 3.9 years in the control arm to greater than 9 years in the treatment arm, as published in the JCO in November 2012. Interestingly, in the EORTC trial from Europe, patients with macroscopic nodal metastasis did not have a survival benefit with a pegylated form of interferon, even with 5 years of therapy. As noted in this publication, the Sunbelt melanoma trial showed no survival benefit for adjuvant high-dose interferon in patients with a single positive sentinel node. Among patients with tumor-negative sentinel node by conventional pathology, but with melanoma detected by RT-PCR, there was again no overall survival benefit to completion lymphadenectomy alone or completion lymphadenectomy plus high-dose interferon. In my practice, I do not recommend high-dose interferon for melanoma patients with microscopic nodal metastasis because of the toxicity of high-dose interferon and the negative results from the Sunbelt randomized trial. However, in patients with microscopic nodal metastasis arising from an ulcerative primary, I would recommend pegylated interferon as first-line therapy for up to 2 years or more, and would at least discuss with patients this treatment option for even the lower risk group with microscopic nodal metastasis arising from a non-ulcerative melanoma, especially with a thick primary. Also, I recommend the high-dose interferon regimen for stage 3C patients with macroscopic nodal metastasis as the first-line therapy after surgery because the previous trials were conducted largely in this group of patients. When it was conceived in 1996, the Sunbelt trial was designed to answer clinical questions that were of great relevance at the time. However, this was nearly 20 years ago, and the questions that it sought to answer are no longer of great clinical relevance, mainly because of new and effective drug therapies for patients with metastatic melanoma, most of them with much less side effects than interferon, and adjuvant trials with these agents are already in progress. At present, alpha interferon, either with the high-dose regimen for 1 year or pegylated version for 2 to 5 years, are the only drugs approved by the FDA for adjuvant systemic therapy, until just a few months ago when the FDA approved the use of ipilimumab for stage 3 melanoma. However, I have concerns about this new checkpoint inhibitor as adjuvant therapy in standard practice, especially at the 10 milligram per kilogram dose, because of the extreme toxicity, which caused half the patients to stop therapy, and there were 5 treatment-related deaths. However, future results with ipilimumab at different dose schedules, and especially with anti-PD-1, which has a more favorable toxicity profile, are likely to usher in an entirely new era of adjuvant systemic therapy for melanoma with nodal metastasis. I'm Dr. Charles M. Balch. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.